Hello, good morning. My name is Dr. Mawsum. Today I'm going to talk about aortic stenosis. The aortic stenosis, it can be a valvular type of aortic stenosis. It can be supravalvular or subvalvular. Most of the common cause is valvular aortic stenosis. So today I'm going to talk about the valvular aortic stenosis. Now talking about the valvular aortic stenosis, the etiology of it. In etiology, it can be congenital, in which it can have a unicuspid, bicuspid, tricuspid morphology, and acquired. In acquired, the common cause is degenerative, that is a senile calcific aortic stenosis. It can be rheumatic. It can be because of infective endocarditis, homozygous type 2 hypercholesterolemia. It can be because secondary to radiation, Paget's disease, or Fabry's disease. Now, in the patients who are presenting with aortic stenosis less than 70 years of age group, the most common cause is bicuspid aortic valve, that is around 50% of it. It can be post-inflammatory, that is 25%. Degenerative, it accounts for about 18%. Unicommissural, that is 3%. Hyperplastic, 2%. And indeterminate, that is 2%. If the patient presents with age group more than 70 years, the most common cause is degenerative, that accounts for about 48%. Bicuspid aortic valve, that is 27% of the causes. Post-inflammatory, that is 23%. And hyperplastic, that is 2%. Now we're going to talk about the calcific aortic stenosis, that's congenital. It is secondary to the heavy dystrophic calcification of a congenitally abnormal valve. It rarely presents before the age of 20. It is slow progressive. It results into important stenosis most often in the 5th and 6th decade of life. It is earlier in unicuspid than bicuspid valves, and male present early as compared to females. In the pathology, there is bulky cauliflower-like mass within the cusp, maximum at the site of commissural fusion or the congenital buttress formation, often extending into the annulus, that's left ventricular aortic junction, and adjacent aorta. The extension of the calcification to the RCC-NCC commissure leads to complete heart block. The valvular orifice is slit-like, often eccentrically located and oriented in a sagittal most often, or a transverse plane, and fixed, which often results into trivial or mild aortic regurgitation. Now we talk about the bicuspid aortic valve. It is the most common congenital heart anomaly. It accounts for about 0.5 to 2% of the general population. The gradual calcification of the bicuspid aortic valve, it results into the significant stenosis, most often in the 5th and 6th decades of life, earlier in the unicommissural, then in the bicuspid valves, and earlier in the male, then in females. Most of the patients are asymptomatic. About 30% of the individuals by bicuspid aortic valves, they develop complication, that is the aortic stenosis. The two cusps of the unequal size, the larger one which is containing a central raphe. The fusion between RCC-LCC is common, that accounts around 86%, and fusion between LCC-NCC is around 3%. The coronary arteries may be abnormal. A left dominant coronary system is more commonly observed with a bicuspid aortic valve. Rarely L kappa may be present. The left main coronary artery may be up to 50% shorter. Occasionally, the coronary ostium may be congenitally stenotic. It can be associated with coarctation of aorta and interrupted aortic arch. The abnormal architecture of the unicommissural or the bicuspid aortic valve, it induces a turbulent flow. The turbulent flow injures the leaflets and it leads to fibrosis, increased rigidity, leaflet calcification, and narrowing of the aortic valve orifice. The bicuspid valves often are associated with dilatation of the ascending aorta, which is related to the accelerated degeneration of the aortic medium that it may progress to aneurysm formation. The structural abnormalities also exist at the cellular level that are independent of the hemodynamic effects. Inheritance. It is mostly sporadic. In 10 to 17% it is inherited. So inheritance is autosomal dominant type with a variable penetrance encompassing the entire spectrum of left heart obstruction, that is the hyperplastic left heart syndrome, aortic stenosis, and coarctation of aorta. The associated syndromes with this can be coarctation or interrupted aortic arch, Williams syndrome, patent ductus arteriosus also associated with the hand anomalies, Turner syndrome, and Sean syndrome. Now we're going to talk about the degenerative aortic stenosis. This is the most common cause of aortic stenosis in adults. In the population-based echocardiographic study, 2% of the people of 65 years of age or older have frank calcific aortic stenosis. 29% exhibit age-related aortic valve sclerosis without stenosis. It is defined as an irregular thickening of the aortic valve leaflets which are being detected by the echocardiography without significant obstruction. The aortic sclerosis is the initial stage of calcific valve disease, and even in the absence of valve obstruction, is associated with 50% increased risk of the cardiovascular death and myocardial infarction. The pathology of calcific aortic stenosis. Earlier it was thought to be caused purely by mechanical factors, but the recent evidence says it is a result of an active inflammatory process which is involving the biochemical, humoral, and the genetic factors in addition to the mechanical factors. The mechanical stress and endothelial damage, it leads to inflammation, which in turn leads to angiogenesis and valve hemorrhage, which leads to fibrosis and eventually calcification and aortic stenosis. The rheumatic aortic stenosis. The diffuse prominent fibrous cusp, thickening of the tricuspid valve with a fusion to a variable extent to one or two commissures, rarely all three. The orifice is approximately center and it is irregular in shape. The calcification is lesser extent. It is bulkiest at the site of the commissural fusion. The rheumatic aortic stenosis is seldom, if ever, isolated. Although at the patient's first operation, this may appear to be the case. In surgical series of apparently isolated aortic stenosis, prevalence of rheumatic etiology is low compared with that when the patients with important mitral valve stenosis are included. Now the pathophysiology. The aortic stenosis, it leads to the resistance of the systolic ejection. There is a systolic pressure gradient between the left ventricle and the aorta. Now this outflow obstruction, it leads to an increase in the left ventricular systolic pressure. As a compensatory mechanism to normalize LV stress, the LV wall thickness, it increases by parallel replication of sarcomeres which are producing a concentric hypertrophy. It follows the Laplace law, that is wall tension is equal to transmural pressure into radius divided by 2 times wall thickness. At this stage, the chamber is not dilated and the ventricular function is being preserved. Now the left ventricular pressure is much greater than aortic pressure during the LV ejection. The atrial contraction, it plays an important role in filling of the left ventricle in aortic stenosis. It raises the left ventricular end diastolic pressure without causing a concomitant elevation of mean LA pressure. This boosted pump function of left atrium, it prevents the pulmonary venous and capillary pressure from rising to the levels that would produce pulmonary congestion, whereas at the same time it maintaining the left ventricular end diastolic pressure at the elevated level necessary for the effective contraction of the hypertrophied left ventricle. Now the loss of the appropriately timed vigorous atrial contraction, as occurs in atrial fibrillation or the atrioventricular dissociation, may result into rapid clinical deterioration in the patient with a severe aortic stenosis. In the aortic stenosis, there is a red loop in the figure which is being shown. The left ventricular emptying is impaired because of the high outflow resistance. The larger pressure gradient to occur across the aortic valve during the ejection such that the peak systolic pressure within the ventricle is greatly increased. This leads to an increase in the ventricular afterload, a decrease in the stroke volume, and an increase in an end systolic volume. The stroke volume, that is the width of the pressure volume loop, it decreases because the velocity of the fiber shortening is decreased by the increased afterload. Because the end systolic volume is elevated, the excess residual volume added to the incoming venous return causes the end diastolic volume to increase. This increases preload and activates a Frank-Starling mechanism to increase the force of contraction to help the ventricle overcome the increased outflow resistance. Now the systemic vascular resistance, it also contributes to the total LV afterload in adult with aortic stenosis. The concurrent hypertension, it increases the total left ventricular load and may affect the evaluation of the aortic stenosis severity. Mild pulmonary hypertension is present in about 1/3 of the adults with aortic stenosis because of a chronic elevation of the LV end diastolic pressure. More severe pulmonary hypertension is seen in about 15% of the aortic stenosis patient. Now, the exercise physiology is abnormal in the adults with a moderate to severe aortic stenosis, and even asymptomatic patients have a reduced exercise tolerance. Because although the cardiac output at rest is within the normal limits, the normal increase in the cardiac output with exercise is blunted. In severe aortic stenosis, there is an abnormal blood pressure response to exercise, The rise in the systolic pressure is less than 10 mm of mercury. Now, the cardiac and the systemic compensatory mechanism that attempt to maintain the cardiac output and arterial pressure are the systemic vasoconstriction, increase in the blood volume, increase in heart rate, and inotropy. Now, the diastolic properties. The LV hypertrophy, it increases the diastolic stiffness. There is a greater intracavitary pressure is required to fill LV filling. This increased stiffness, it contributes to the elevation of the LV diastolic filling pressure of the ventricular diastolic volume. The diastolic function may revert toward normal with the regression of hypertrophy following surgical relief of aortic stenosis, but some degree of long-term diastolic function typically persists. Ischemia. In the patient with aortic stenosis, the coronary blood flow address is elevated in absolute terms but is normal when the corrections are made for the myocardial mass. The hypertrophy LV muscle mass, increased systolic pressure, and prolongation of ejection all elevate to myocardial oxygen consumption. The abnormally heightened pressure compressing the coronary arteries may exceed the coronary perfusion pressure, and shortening of the diastole, it interferes with the coronary blood flow, thus leading to an imbalance between the myocardial oxygen supply and demand. The myocardial perfusion is also impaired by the relative decrease in the myocardial capillary density as the myocardial mass it increases, and by the elevation of the LV and diastolic pressure, which lowers the aortic LV pressure gradient and diastole, which is important, that is the coronary perfusion pressure gradient. Now, this underperfusion may be responsible for the development of subendocardial ischemia, especially when the oxygen demand is increased or the diastolic filling period is reduced, for example, in tachycardia, anemia, infection, pregnancy. Patient develops symptoms of angina even with the normal coronary arteries. Now, here's a flowchart which is showing the pathogenesis of aortic stenosis. The aortic stenosis is basically the LV outflow obstruction. So this leads to increase in the LV systolic pressure, which leads to increase in the LV mass, which eventually leads to LV dysfunction and LV failure. The LV increase in the left ventricular emptying time, it causes two types of things, that is myocardial oxygen consumption is increased and the diastolic time is decreased. This eventually leads to decrease in the myocardial oxygen supply, which leads to myocardial ischemia and LV failure. The LV outflow obstruction, it increases the LV diastolic pressure, which leads to myocardial oxygen supply decrease and myocardial ischemia and LV failure. And aortic pressure is reduced, which eventually leads to decrease in oxygen supply, myocardial ischemia and LV failure. Now, the clinical features. The cardinal symptoms are chest pain, that is angina. This is because of the reduced coronary flow reserve and an increase in the demand, high afterload. Then syncope or dizziness, that is exertional pre-syncope, because of the fixed cardiac output and a vasodepressor response. Dyspnea on exertion and rest, impaired exercise tolerance, and other signs of LV failure, that is in the later stages because of the diastolic and the systolic dysfunction. The patient with a congenital or the rheumatic aortic stenosis present with the symptom most commonly in the 5th or 6th decade of life. Patient with the degenerative calcific aortic stenosis, symptoms commence in the 7 to 9th decades. Patient may be asymptomatic and refer because of the cardiac murmur on the routine checkup or after 2D echocardiography for screening. The aortic stenosis is rarely of clinical importance until the valve orifice has narrowed to approximately 1 cm square. The aortic stenosis usually has an asymptomatic latent period of around 10 to 20 years. The symptoms gradually develop. The exertional dyspnea is the most common initial complaint, even in the patient with a normal LV systolic function. The classic triad of effort dyspnea, angina, and syncope is present in about 1/3 of the patients. Chest pain, angina, which has been described earlier. Now, the dyspnea. The mechanism of the exertional dyspnea may be the LV diastolic dysfunction with an excessive rise in the end diastolic pressure, which is leading to pulmonary congestion. Alternatively, the exertional symptoms may be a result of the limited ability to increase the cardiac output with exercise. More severe exertional dyspnea with orthopnea, paroxysmal nocturnal dyspnea, and pulmonary edema, it reflects varying degree of the pulmonary venous hypertension, which are the symptoms of later stage. Syncope. The sudden and transient loss of consciousness, which has been associated with the loss of postural tone with a spontaneous recovery. Presyncope, lightheadedness or dizziness, transient episode of altered consciousness with a loss of postural tone, no loss of consciousness. Syncope may be accompanied by convulsions. Mechanism of syncope. Decrease in the cerebral blood flow due to the reflex peripheral vasodilatation due to exercise and setting of fixed cardiac output. The exercise leads to marked increase in the LV pressure, which is leading to stimulation of LV mechanoreceptors, causing a reflex vagal stimulation and inhibition of sympathetic tone. The myocardial ischemia causing hypertension and bradycardia. Arrhythmias can be ventricular tachycardias, atrial fibrillation, or AV block. Syncope at rest is being caused by arrhythmias. Now, the stages of syncope. The first stage, which lasts for around 20 to 40 seconds, is due to the vasodepression, sudden fall of blood pressure, lightheadedness, pallor, transient loss of consciousness. At this time, the ECG is normal and the heart sounds are distant. In the second stage, it can be secondary to decreased coronary blood flow. There can be presence of stenosis, absent pulse, absent heart sounds, twitching of body, seizures, and abnormal ECG. There can be STs or there can be ventricular tachycardias, AF, AV block, or ventricular fibrillation or asystole. Now, the gastrointestinal bleeding may develop in the patient with severe aortic stenosis, often associated with angiodysplasia, most commonly of the right colon or other vascular malformation. This complication arises from the shear stress induced platelet aggregation with a reduction in high molecular weight multimers of 1 millibron factor and increase in the proteolytic subunit fragments. These abnormalities correlate with the severity of AS and are be correctable by AVR. This is known as Hyde syndrome. Infective endocarditis is a greater risk in younger patient with a mild valvular deformity than in the older patient with a rock-like calcific aortic deformities. The cerebral emboli resulting in stroke or transient ischemic attacks may be caused by the microthrombi on the thickened bicuspid valves. Now, the prognostic importance of symptoms. The presence of symptoms, that is angina, congestive heart failure, syncope or resuscitation from sudden death with severe aortic stenosis is a class 1 indication for surgery because once the symptoms are present, the average survival is only 2 years with less than 20% chances of surviving more than 5 years. Mean survival 1 year for patient who has developed symptoms of congestive heart failure, 3 years for the patient with syncope, and 5 years with patient with angina. The physical examination. The key features are palpation of the carotid upstroke, evaluation of systolic murmur, assessment of splitting of the second heart sound, and examination of signs of heart failure. Now, the carotid upstroke directly reflects the arterial pressure waveform. A slow rising, late peaking, low amplitude carotid pulse, that is the power retarded carotid impulse, is present in patient with aortic stenosis. When present, this finding is specific for severe aortic stenosis. However, many arteries with aortic stenosis have a concurrent condition such as AR or systemic hypertension that affects the arterial pressure curve and the carotid impulse. With severe aortic stenosis, there would be radiation of murmur to the carotids, which may result into palpable thrill or carotid shudder. The apex beat is sustained and it becomes displaced inferiorly and laterally with LV failure. The presystolic distension of left ventricle, that is the prominent precaudal A wave, is often visible and palpable. A hyperdynamic left ventricle suggests a concomitant aortic regurgitation and or mitral regurgitation. A systolic thrill is usually best appreciated when the patient leans forward during full expiration. It is palpated most readily in the second right intercostal space or suprasternal notch and is transmitted along the carotid arteries. The jugular venous pulse may show prominent A waves reflecting the reduced right ventricular compliance consequent to the hypertrophy of the interventricular septum, thus known as a Burnham effect. In auscultation, the ejection systolic murmur of aortic stenosis typically is late peaking and it is heard best at the base of heart with radiation to the carotids. The suggestion of the murmur before A2 is helpful in differentiation from a pan-systolic mitral murmur. In the patient with a calcific aortic valve, the systolic murmur is loudest at the base of heart, but high-frequency components may radiate to the apex, the so-called Galliverdian phenomenon, in which the murmur may be so prominent that it is mistaken for the murmur of mitral regurgitation. In general, a louder and late peaking murmur indicates more severe stenosis. High-pitched decrescendo diastolic murmur secondary to aortic regurgitation are common in patients with dominant aortic stenosis. The splitting of the second heart sound is helpful in excluding the diagnosis of severe aortic stenosis because the normal splitting it implies the aortic leaflets are flexible enough to create a audible closing sound. With severe aortic stenosis, the second heart sound may be single because the calcification and immobility of the aortic valve make A2 inaudible. Closure of the pulmonary valve is buried in the prolonged aortic ejection murmur, or the prolongation of the LV systole, it makes A2 coincide with P2. The paradoxical splitting of S2, which suggests an associated left bundle branch block or LV dysfunction, may also occur. Thus, in the older individuals, normal splitting of S2 indicates a low likelihood of severe aortic stenosis. The intensity of the systolic murmur, it varies from beat to beat when the duration of the diastolic filling varies, as in the atrial fibrillation or following a premature contraction. This characteristic is helpful in differentiating the AS from MR, in which the murmur is usually unaffected. The murmur of valvular aortic stenosis is augmented by squatting, which increases the stroke volume. It is reduced in intensity during the strain of valsalva maneuver and when standing, which reduces the transvalvular flow. Here is a table which has been showing the signs and the correlation with the severity. On the left side are the signs and the right side there is a correlation with the severity. So JVP prominent A wave, no, it is not related. If at all the carotid delay anacrotic, yes, it is related to the severity. If the A2 is audible over the carotids, then no. If the apex is sustained, yes. If it is enlarged and displaced, yes. If there is a presence of thrill, no, it is not related to the severity. Cardiomegaly, yes. Soft S1, yes. Paradoxical S2, yes. S3 and S4, yes. In the murmur, if at all the intensity is not related to the severity, but the late peaking is definitely associated with the severity. In the ECG, the signs of left atrial enlargement and left ventricular hypertrophy, they are related with the severity. Now, the aortic stenosis and the X-ray, what we find, the left ventricular hypertrophy may be seen as a rounding of the cardiac apex. The post-stenotic dilatation of the proximal aorta, it suggests stenosis as at the valvular level. Now, the aortic valve calcification, it occurs in majority of the patients who have significant stenosis. Here is an X-ray which has been showing the calcification of aortic valve. There is dilated aortic arch and there is an increased convexity of the left heart border with an overall enlarged heart size. Now, the electrocardiography. The ECG often shows left ventricular hypertrophy with or without the repolarization abnormalities, that is strain pattern. However, the severe aortic stenosis can be present without the ECG evidence of LVH. The left bundle branch block may be present. Extensive calcification of the conduction system may result into the first degree atrioventricular block and rarely complete heart block. A normal ECG can be seen in about 10 to 20% patients who have significant aortic stenosis. Now, the echocardiography. The echocardiography has emerged as a principal method of establishing the diagnosis of the aortic stenosis. Here we can analyze the valve anatomy, the severity of the stenosis, either valvular or non-valvular condition, the left ventricular response to the pressure overload. This requires a special skill and expertise. It is a subjective modality. The characteristics of degenerative, that is a calcific disease, it includes increase in the echogenicity and reduced systolic opening. Commissural fusion and coexistent mitral valve involvement are the distinguishing features of rheumatic aortic valve disease. The severity of the stenosis can be represented by aortic jet velocity, the estimated maximum and mean transaortic pressure gradients, and estimated valve area. The pressure difference that causes the blood to flow between the two chambers can be estimated using a modification of the Bernoulli equation. The maximum gradient can be determined by from the maximal velocity, and the mean gradient can be determined by integrating the instantaneous pressure gradients over the systolic ejection period. The aortic valve area that is being calculated on the basis of the continuity principle. Now, the left ventricular hypertrophy may result into LV diastolic dysfunction, which can be evaluated by echocardiographic measurements. The echocardiography also allows evaluation of other potential causes of systolic murmur, such as mitral regurgitation, hypertrophic cardiomyopathy, coarctation of aorta, and ventricular septal defect. A large number of patients, that's approximately 80%, who have aortic stenosis, also have some degree of aortic regurgitation that should be quantified. Now, the cardiac catheterization. It is an invasive method. Invasive measurements of the transaortic valve gradient and the calculation of aortic valve area by Gaussian formula are needed when good quality echocardiographic data are not available. The patient at risk of coronary artery disease require coronary angiography, so the bypass grafting can be performed at the time of valve replacement. Now, stress testing. It is contraindicated in the symptomatic patient who have aortic stenosis. It may be helpful when the actual presence of symptoms is unclear or when the symptoms appear to be out of proportion to the severity of the stenosis. The management of the patient with aortic stenosis. Now, the treatment of the patient who have aortic stenosis is dictated by the presence or absence of the symptoms. The asymptomatic patient should receive antibiotic prophylaxis for endocarditis. In addition, they should be provided with education regarding the expected symptoms and the time course for the disease progression. Now, on the right side, there is a flow chart of the management. Now, the aortic stenosis, which is being determined on the basis of echocardiography, where we look out for the valve anatomy, the severity of the stenosis, we assess the other valves along with the aortic valve, and we also see the left ventricular response to the pressure overload. Now, if there is presence of symptoms, then we have to look out whether there is any contraindication to the surgery. We have to look for the coronaries and optimize the hemodynamics and go for an aortic valve replacement. The processes which can be used are pulmonary homograft or bioprocesses or mechanical processes. Now, if the patient does not have symptoms, then we have to treat the risk factors. We have to educate the patient. We have to go for endocarditis prophylaxis, and echocardiography follow-up is being done. Now, at how many years do we have to call the patient is being determined on the basis of aortic jet velocity. If it is less than 3 meter per second, then we have to call the patient for follow-up every 4 to 5 years. If it is between 3 to 4 meter per second, then every 2 years. And if it is greater than 4 meter per second, then we have to call the patient annually for the follow-up. Now, the modification of risk factors, that is hypertension, smoking, diabetes, elevated LDL cholesterol, should be also a major focus for treatment to prevent concurrent coronary artery disease. Now, statins and aortic stenosis. Several retrospective studies have demonstrated that a statin treatment is associated with lower hemodynamic progression of aortic stenosis. Intensive lipid lowering therapy did not halt the progression of calcific aortic stenosis or induce its regression. So, the final conclusion on the efficacy of statin treatment can, however, only be drawn by the large prospective randomized controlled trials. Now, the prospective studies have shown that the average rate of increase in the maximum aortic jet velocity is around 0.3 meter per second per year, with an increase in the mean gradient of greater than 7 millimeter per mercury per year and a decrease in the aortic valve area of around 0.12 centimeter square per year. However, the rate of the hemodynamic progression in an individual may be more variable. Now, the surgical consideration. The operative mortality is ideally to be in range of around 2 to 3%. However, it may be as high as 10% in elderly and even higher in the presence of significant comorbidity. The prosthetic valve related long term morbidity and mortality must be taken into account. Thromboembolism, bleeding, endocarditis, valve thrombosis, paravalvular regurgitation, and valve failure that occur at the rate of around 2 to 3% per year. Now, the risk stratification by echocardiography. The peak aortic jet velocity and LV ejection fraction, as well as the rate of hemodynamic progression, have been identified as independent predictors of outcome, that is retrospective. The aortic valve calcification has turned out to be a powerful independent predictor of the outcome. The combination of notably calcified valve with a rapid increase in the velocity of more than 0.3 meter per second from one to following visit within 1 year has been shown to identify as high risk of group of patients. Approximately 80% of them require surgery or they'll die within 2 years. Now, the symptomatic aortic stenosis. The prognosis of the symptomatic patient is extremely poor without surgical treatment. In recent studies, the symptomatic patient with aortic stenosis who have refused surgery have had 5-year survival rate of only 15 to 50%. The option for the valve replacement include the pulmonary autograft procedure, bioprocesses, and mechanical valve, and recently percutaneous aortic valve replacement. Now, This is a table which has been showing the stages of valvular aortic stenosis on the basis of AHA guidelines 2020. Now, stage A, that is by definition at risk of aortic stenosis. In this, the valve anatomy can be bicuspid aortic valve or other congenital valve anomaly, or there can be presence of aortic valve sclerosis. In the valve hemodynamics, the maximum velocity is less than 2 meter per second with a normal leaflet motion. The hemodynamic consequence would be none, and there is no presence of symptoms at this stage. In stage B, that is progressive aortic stenosis, in the valve anatomy, there would be mild to moderate leaflet calcification or fibrosis of bicuspid or a tricuspid valve with some reduction in the systolic motion, or it can be rheumatic valve changes with commissural fusion. The valve hemodynamics would be velocity would be between 2 to 2.9 meter per second with a mean pressure gradient of around less than 20 millimeter of mercury. That is mild. In moderate aortic stenosis, the velocity would be around 3 to 3.9 meter per second with a gradient of around 20 to 39 millimeter of mercury. In this stage, the hemodynamic consequence would be early LV diastolic dysfunction and the EF would be normal. The symptoms would not be present at this stage. Now, the stage C, that is in asymptomatic severe aortic stenosis. C1, that is asymptomatic severe aortic stenosis, the valve leaflet would be severe calcification, fibrosis, or congenital stenosis with a severely reduced leaflet opening. The hemodynamics would be the velocity would be more than 4 meter per second, mean gradient would be more than 40 millimeter of mercury. The valve area would be typically less than 1 centimeter square. Very severe aortic stenosis, the aortic valve velocity would be more than 5 meter per second with a mean gradient more than 60 millimeter of mercury. Now, the hemodynamic consequence over here would be LV diastolic dysfunction, mild LV hypertrophy, and normal ejection fraction. The symptoms would be none. The exercise testing is reasonable to confirm symptom status. Now C2, that is asymptomatic severe aortic stenosis with the LV systolic dysfunction. In this, the anatomy would be severe left leaflet calcification, fibrosis, or congenital stenosis with a severely reduced leaflet opening. The velocity would be more than 4, the mean gradient would be more than 40 millimeter mercury. The valve area would be less than 1 centimeter square. The hemodynamic consequence would be the EF is less than 50%. The symptoms would not be present at the stage. Now D, that is symptomatic severe aortic stenosis. Now the symptomatic severe high-grade aortic stenosis, the anatomy would be leaflet calcification, fibrosis, congenital stenosis with severely reduced leaflet opening. The hemodynamics, the velocity would be more than 4 meter per second, the gradient would be more than 40, the area would be less than 1 centimeter square. It can be mixed aortic stenosis with aortic regurgitation can also be there. The hemodynamic consequence would be LV diastolic dysfunction, hypertrophy, and pulmonary hypertension may be present. The symptoms here would be exertional dyspnea, decrease in exercise tolerance or heart failure, exertional angina, exertional syncope or presyncope. Now D2, symptomatic severe low flow, low gradient aortic stenosis with reduced ejection fraction. Here the severe leaflet calcification, fibrosis with reduced leaflet motion. The hemodynamics, the area would be less than 1 centimeter square. The velocity would be less than 4 meter per second and mean gradient would be less than 40 millimeter of mercury. But in the dobutamine stress echocardiography, the area would be less than 4 centimeter square with the velocity which may increase to more than 4 meter per second at any flow rate. The consequence of a hemodynamic consequence would be LV diastolic dysfunction, hypertrophy, EF less than 40%, 50%. The symptoms would be heart failure, angina, syncope or presyncope. Now the symptomatic severe aortic stenosis, D3. Symptomatic severe low-grade aortic stenosis with normal LVF or paradoxical low-flow severe aortic stenosis. Anatomy would be same. The hemodynamics, the area would be less than 1 centimeter square with a velocity less than 4 meter per second. The mean gradient would be less than 40 millimeter of mercury and stroke volume index would be less than 35 milliliter per meter square. Measure when the patient is normotensive, that systolic pressure is less than 140 millimeter mercury. The consequence would be increase in the LV relative wall thickness, small LV caliber with a low stroke volume, restrictive diastolic filling, and the EF would be greater than 50%. The symptoms would be heart failure, angina, syncope or presyncope. Here is the slide which has been showing the class of recommendation and the level of evidence. Now I'm going to talk about timing of intervention of aortic stenosis according to the AHA guidelines 2020. Now 1A indication in the adults with severe or high gradient aortic stenosis, that is stage D1, and symptoms of exertional dyspnea, failure, angina, syncope or pre-syncope by the history or on exercise testing, AVR is indicated. 1BNR in asymptomatic patient with severe aortic stenosis and an LV EF of less than 50%, that is stage C2, AVR is indicated. 1BNR in asymptomatic patients with severe aortic stenosis, that is stage C1, who are undergoing cardiac surgery for other indication, AVR is indicated. Then 1BNR in asymptomatic patient with low flow, low gradient, severe aortic stenosis with reduced EF, stage D2, AVR is indicated. In 1BNR in symptomatic patient with low flow, low gradient, severe aortic stenosis with a normal EF, that is D3, AVR is recommended if AS is the most likely cause of symptoms. Now 2A, level of evidence BNR, in apparently asymptomatic patient with severe aortic stenosis, stage C1 and low surgical risk, AVR is reasonable when an exercise test demonstrates decrease in exercise tolerance or a fall in the systolic pressure which is greater than 10 mm of mercury from baseline to peak exercise. Now 2A, level of recommendation BR, in asymptomatic patient with very severe aortic stenosis, defined as an aortic velocity of more than 5 meters per second and low surgical risk, AVR is reasonable. Now 2A, level of evidence BNR, in apparently asymptomatic patient with severe aortic stenosis, stage C1 and low surgical risk, AVR is reasonable when the serum, the BNP level is greater than 3 times normal. Now 2A BNR in asymptomatic patient with a high gradient severe aortic stenosis, stage C1 and low surgical risk, AVR is reasonable when the serial testing shows an increase in jet velocity more than 0.3 meter per second per year. Now 2B and level of evidence BNR in asymptomatic patient with a severe high grade aortic stenosis, that is stage C1, and a progressive decrease in LVEF on at least 3 serial imaging studies to less than 60%, AVR may be considered. Now 2B, level of evidence C, expert opinion, in the patient with moderate aortic stenosis, stage B, who are undergoing cardiac surgery for other indication, AVR may be considered. Now here is a flowchart which is showing the timing of intervention for the aortic stenosis. Now there is an abnormal aortic valve with a reduced systolic opening. Now whether the patient is symptomatic or asymptomatic. Now the symptoms are due to the aortic stenosis. Then we have to classify whether it is severe. Now the severe has been defined by velocities more than 4 meters per second and the gradient is more than 40 millimeter mercury. Then we have to opt for the aortic valve replacement. It can be surgical or we can opt for TAVI. Now, if the velocity is less than 4 meters per second and the valve area is less than 1 centimeter per square, if at all yes, then severe aortic stenosis stage 2, then we have to do the dobutamine stress echo. If the velocity it increases more than 4 meters per second at any flow rate, then we have to opt for the aortic valve replacement. If it is no, if the severe aortic stenosis, then stage D3, the valve area is less than 0.6 centimeter square per meter square and the stroke volume is less than 35 milliliter per meter square. The aortic stenosis most likely the cause of symptoms, then we have to opt for the aortic valve replacement. Now the patient does not have symptoms. That is, the aortic stenosis is at stage C where the velocity is greater than 4 meters per second. Then we have to see whether the ejection fraction is less than 50%. Yes, then we have to opt for the valve replacement. If at all we are opting for other cardiac surgery, then we have to go for AVR also. Now the exercise tolerance test with a decrease in blood pressure and exercise capacity, then we have to go for a surgical valve replacement. If the velocity is more than 5 meters per second, if the BNP is greater than 3 times the normal, there is a rapid disease progression and there is a low surgical risk, then we have to go for a surgical aortic valve replacement. If the EF is less than 60% on 3 serial studies, then we have to go for the surgical valve replacement. Now stage B aortic aortic stenosis stage B, where the velocity is between 3 to 3.9 meter per second. If at all we are going for other cardiac surgery, then we should also go for aortic valve replacement. Now the choice of intervention, that is the mechanical versus bioprosthetic aortic AVR. Now, the 1C expert opinion, in the patient with an indication of AVR, the choice of prosthetic valve should be based on a shared decision-making process that accounts for patient values and preferences, and it includes the discussion of indication for and the risk of anticoagulation therapy and the potential need for and the risk associated with the valve-free intervention. Now, the class of recommendation 1, level of evidence C expert opinion, for the patient of any age requiring AVR for whom the vitamin K antagonist anticoagulant therapy is contraindicated, cannot be managed appropriately, or is not desired, then a bioprosthetic AVR is recommended. Now, class of recommendation 2A and level of evidence B. For the patient which is less than 50 years of age who do not have any contraindication to anticoagulation and require an AVR, it is reasonable to choose a mechanical aortic prosthesis over a bioprosthetic valve. Now we have class of recommendation 2A, level of evidence B and R. For the patients between 50 to 65 years of age group who require an aortic valve replacement and who do not have a contraindication to anticoagulation, it is reasonable to individualize the choice of either mechanical or bioprosthetic aortic valve with the consideration of individual patient factors and often informed shared decision making. Now to ABR, in patients greater than 65 years of age group who require AVR, it is reasonable to choose a bioprosthetic valve over a mechanical one. Now to B, level of evidence B, in the patient less than 50 years of age who prefer bioprosthetic aortic valve and have appropriate anatomy, replacement of aortic valve by pulmonary autograft, that is the Ross procedure, may be considered as a comprehensive valve care. This is a flowchart which is showing the choice of the surgical aortic valve replacement versus TAVI when the AVR is indicated for the valvular aortic stenosis. Now, the adult patient with the aortic stenosis, the indications have already been discussed before. So, this has to be a shared decision making when the patient and the heart valve team with the discussion of the surgical and TAVI. Now, the risk assessment is to be done. If the patient does not have risk, then we have to look whether the vitamin K antagonist anticoagulation can be taken or not. If at all there is no contraindication to the anticoagulation, or then we have to look for the patient age group. If at all is less than 50 years, then first choice would be the mechanical aortic valve. The class of recommendation is 2A, or we can go for pulmonary autograft, that is 2B. Now, if at all the age group is between 50 to 65, then we have to go, can be either mechanical or bioprosthetic valve, that is class of recommendation is 2A. If the age group is greater than 65, then we can go for bioprosthetic valve, that is class of recommendation is 2A. If the patient cannot take a vitamin K antagonist anticoagulation, that is contraindicated or cannot be managed or is not desired, then we have to offer bioprosthetic valve. Now, in the bioprosthetic valve, now the patient with a symptomatic severe aortic stenosis, that is D1, D2, D3 class, or asymptomatic severe aortic stenosis with a low ejection fraction. Now, if at all it is not there, then we have to go for a surgical valve replacement, that is bioprosthetic valve can be placed. Now, if the patient has a valve and vascular anatomy are favorable and they're suitable for transfemoral TAVI, if at all no, it is not suitable, then we have to go for surgical. And if at all yes, then we have to see the life expectancy. If the age or is less than 65, then we have to go for a surgical replacement. If the age is between 65 to 80 years, then we have to surgical replacement, that is the first choice, that is class of recommendation is 1, and transfemoral TAVI can also be done, that is class of recommendation is 1. If the age is greater than 80 years, then the TAVI is opted first. Now, if the patient risk assessment is high, if there is an STS is more than 8%, or the frailty measures more than 2, or the less than 2 organ systems are there, or procedure specific impediment, then we have to see life expectancy with an acceptable quality of life which is more than 1 year. If the patient preferences and values, yes, if the vascular and the valve anatomy is suitable, then we have to go for TAVI, and if it is not suitable, then we have to go for palliative care. And if the life expectancy is less than 1 year, then we have to go for palliative care.